Well, thank you everybody for joining us again today. This is going to be good. We did the first training for naloxone, for the Naloxone Kit in October, and
You can do it back in October.
yeah, and for me anyway, it was very helpful just to know what's in here and how to use it and why and all of the reasons behind it. So we're looking forward to that again today. But let's just open in a word of prayer. You can have your All right, let's open. Lord, thank you for this time you've given us to learn and to grow in the way that we can serve others. We pray you will lead us and guide us by your Holy Spirit, that everything we do and say and think today will be to your honor and glory and praise and to the extension of your kingdom. In Jesus' name, amen. 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 So over the last couple of weeks, we have been talking about our downtown neighbors and how we can serve them through awareness and advocacy and action. And we have talked about general situation downtown. We have talked about addictions. We have talked about mental health issues. We have talked about other issues and holistic health care. And all in that context of awareness and advocacy and action. And Bill is the director of Radicare Ventures, which really serves the people that are vulnerable and especially that have barriers to education, to employment, not education, barriers to employment. Yeah, maybe that's true. He serves them in a real holistic program, and that's what has really been a blessing for us to work with him in the cathedral. So I just wanted to ask you to take a minute or two to introduce Radicare, so that people know that context.
Yeah, Radicare Ventures is a nonprofit social enterprise that hires people who have employment barriers. So we train people on property maintenance work primarily. So all folks are general laborers and they're able to, do garbage cleanup, needle disposal, graffiti removal, pressure washing, things like those. We also give them, obviously a ground for introducing soft skills, which is very important for the success of employment and long-term stable employment. So we have a full-time social worker who helps them with that, kind of building up conflict resolution skills, how to work with a team-based setting, how to get along with other people in a team setting. Social worker also helps our staff because a lot of them are experiencing homelessness to find housing and also alternative income as well, just to bridge the gap between our income they're generating and just some supplemental income. Or they help them with finding health benefits, for example, to cover for prescription drugs, which would not be covered if they don't have the coverage. And we also I offer kind of an area monitoring service for properties. So instead of hiring a security guard or using 911. We have an outreach worker who is trained in mental health and crisis intervention and are able to engage with people just face to face without having to escalate to a situation where law enforcement and security is involved. And lastly, we have the consultation and kind of a training on how do you interact with people experiencing vulnerabilities in a respectful and compassionate manner that both fits the needs of the business or the property, which is obviously not having this getting vandalized. And, if people are sleeping in front of the door and you need to have access to the door, how do you ask them to kindly move to an alternative space, right? The objective of the training is to recognize that, there are systems in place that are, not allowing these people to move forward to the next stage. And those are systemic, and building that compassion within us to recognize that, people are experiencing homelessness and addiction, not because of individual factors, but because of a lot of different complexities that we've been talking about, which builds some empathy when we are trying to respond to these situations, so we don't, ourselves escalate to a situation where we just call 911 right away. It just shines some humanity into the people that we see, who are in house every day. But yeah, that's a general overview of what we do as a company. But yeah.
Thank you. And Bill's company, Radicare Ventures, has a wonderful website. So if you want more information or anything, any questions or more details, look at his website, which is
RadicareVentures.ca. What's the next?
One question. Bill, yeah, I actually looked at the website last
Oh.
Monday. You don't have charitable status, so, so can people donate and receive? I
Yeah.
didn't see anything on your website about donations.
Yeah, so Radicare Ventures is set up as legally a for-profit corporation.
Oh,
so it
okay.
is a separate company.
Okay,
It's just that in our ownership, we're amending it so that the revenue generated from this for-profit company goes toward a nonprofit. So it's a nonprofit owned social enterprise. So if we do ever sell the company, we have to abide by the bylaw. We can't just sell it to anyone. We have to sell it to like a charity, for example, or a nonprofit organization. On a nonprofit side, we have Radic Calgary, which hosts the Papa Care Village, and that's the festival that brings together social services, health services, one-stop shop, so people can access all services at once. So that one is a nonprofit organization. We have to wait a year until we can apply for charitable status. So we're just in the process of waiting for the year to lapse. But yeah.
That's good. Okay, so we're going to look at our naloxone kit, but before we get into exactly what we do with needles and everything, we want to talk about when you use it, because you don't obviously just come up to somebody and stick them with a needle. That doesn't make them too happy.
Do we want to do introductions?
Oh, yes.
Sorry, we should have done that. My apologies.
No,
okay.
All right.
Okay, my name is Bill. I'm the managing director of Radicare Ventures. I'm also a second year nursing student at University of Calgary. I've been working in the frontline homeless sector for the past 2 years, working at the Calgary Drop-In Center as an outreach worker at State of Alberta. I also work hospital security and I teach first aid.
Never sleeps. And I'm Wendy Desan, and I'm a member of the Cathedral and help to coordinate the downtown focus group and our training here.
My name is Salam. I work.
My name's Matt and I do AV at the Cathedral.
I'm Sandy. I'm husband of Diane, and I'm just curious and wanting to understand how to deal compassionately with people I might encounter downtown, and I guess also wanting to face certain fears.
I'm Diane and I'm a member of the Cathedral. And similarly, to realize it's not about me and my fears, but about them. So yes, this has just been so helpful.
And I'm Ruth. I'm a member.
Reverend Lino Crow. I'm the incubator of St. Paul Dinka Anglican Southeast. We are now sharing St. Luke's, but we have been here before we become a parish. We have been here in 2003 until 2007, and I was very close. We have been together. So when I just learned that there is training today, luckily we do have a service in the afternoon. And I'm off today, then I prepare to come because I'm doing 2 jobs. I'm working in long-term care for disabled people, dementia people. I've been there now for 21 years doing that job. So I'm doing 2 pastoral care for these people, and I'm serving God on this side. So today I'm off from my work. So I say I better come and attend this training. So I'm really happy to see I came in and I got those after years.
Wonderful. All right, so let's just review about checking for responsiveness and unresponsiveness, because we don't administer naloxone to responsive people.
Yes, actually, let's back up a little bit more. Let's talk about what naloxone is used for
Yes,
in general. Does anyone know? What is naloxone used for?
Overdose,
Overdose. What kind of overdose?
like if you take fentanyl
Mm-hmm.
or morphine
Mm-hmm.
or heroin.
Mm-hmm.
These three, when you take it, then you are overdose, you use it to reverse.
Yeah.
the action.
Yeah. So morphine, fentanyl, heroin, those are all drugs of opiates. So in general, naloxone only works on opiate drugs. So some examples you already listed. Opiates have been developed to medically treat pain. Basically, we have receptors in our body that opiates attach to, and it induces a pain relief effect. Some side effects along with opiates include kind of a euphoria. So that's also another way that drugs sometimes can be misused, is to kind of get the high of euphoria. It does feel good. That's why it's a pain relief medication. If you have ever been into the hospital for any sort of broken bone or any very painful injuries, it is very likely that you have received an opiate before. Even for after surgery, a lot of times people are prescribed with opiate medication to manage the pain. Unfortunately, back in the 80s and 90s, opiate medication has been misadvertised. The safeness of opiates and the addictive nature of opiates have been miscommunicated intentionally by pharma producing companies, and opiates have been mass introduced in kind of the North American market as something that's safe and that can treat pain. So what it turns out to is a lot of folks that we see today, because 80s and 90s wasn't that long ago, is that they are addicted to opiates, not because of experimentation with drugs or anything like that, but because of a medical procedure. And they are on opiates, and suddenly their supply gets cut off from a legal source, from a doctor's prescription, but they are actually developing dependency on the medication. And without a legal source of a prescription drug, they then unfortunately have to turn toward street drugs to kind of maintain their dependency. And we know for street drugs today is that they are highly toxic. What that means is that drug dealers are not measuring specifically what kind of substance they're putting into the product. In a fentanyl rock commonly you see on the street, we have different components of it. It's not just pure fentanyl in there. Because if pure fentanyl of this size, which oftentimes it is fatal. So you can't be consuming that kind of fentanyl amount. Instead, what's mixed in there include, protein powder, like baby formula, random stuff like that. Laxatives, like they literally mix random stuff. They're also mixing other drugs into those rock, so it becomes more potent. Potent just means strong. So there we are seeing back in last year a lot of mixing of what we call benzodiazepine. Benzodiazepine is a class of drug that's a central nervous system depressant. So what it means is that it's like the same class as alcohol, pretty much. And what alcohol does to our body is slows down our breathing. We kind of become intoxicated, and we're not able to have eventually you're becoming unconscious. So it's a very similar presentation on all these drugs, but ultimately the drugs act on different receptors in our body. So naloxone only works on opiate receptor. Benzodiazepine acts on a different receptor. So naloxone coming in, it's not gonna block a benzodiazepine receptor. It's only gonna block opiate receptor. So if you're consuming alcohol, you're consuming benzodiazepines or any other drugs, naloxone is not gonna have any effect on that. So what this means too is that if you inject naloxone into someone who doesn't have opiate, you're not gonna do anything to them. It's gonna hurt because it's a needle, but otherwise, there's no physiological reaction that's gonna be created in the body. This makes naloxone very safe to use. And that's why we have naloxone available for take-home usage. So any person without any medical training per se can use naloxone. Before, it used to be a nurse has to get a prescription from a doctor to be able to give it to a patient. But because of the crisis that we have with death from opiate poisonings every single day, governments across Canada has been saying, hey, we need to distribute this to as many people as possible. So that's kind of a general overview of what naloxone is used for. Now,
Any questions about that? so
Yeah.
far? Let me go.
no, you see some. It's Chris. Hey, how's it going?
Yes.
Yeah, we got a whole
Good
house
turnout.
today. Yeah.
Very good. Hello.
We had a
Good.
problem with the screen, so we're just using Matt's phone.
Oh, okay. Thank you, Matt. I wonder what's up with this. Oh, our internet.
It's the internet.
Yeah, unfortunately.
I'll take a look at it after.
Yeah, thanks so much for helping problem solve.
Yes. Thank
No,
you.
all good. Yeah. So in our naloxone kit, Alberta government distributes intramuscular naloxone kit for free. Intramuscular means injection within the muscle. Intras within, muscular means muscle. So these kits can be obtained at any pharmacy that has stock. I mean, if they don't have stock, then
Yeah.
different pharmacy will work.
And you just ask them. You
Yeah.
just say, could I have a naloxone kit? They don't ask any questions about what are you gonna do with it or anything, and
Yeah.
they'll just say, sure, and they'll give you one. So yesterday, I was going around getting 8, so I'm sure they thought, what are we doing with so many kits? But
Yeah.
Yeah,
So inside the kit, I'm just gonna introduce what's inside here. You're gonna have a instruction manual in which hopefully you'll familiarize during this class so you don't read it during an actual emergency.
Yeah.
You're going to have a barrier CPR rescue mask inside this package. You're also gonna have gloves as well. You're gonna have alcohol wipes. And then inside the other package, you're gonna have 3 vials. That's 1 milliliter of naloxone or 0.4 milligram of medication. You're also going to have 3 bandage point syringe. Yeah. So that's what's inside the kit.
we can we just tell them what a vanishing point syringe means. This is
Here.
very encouraging. Very well.
Yeah. The reason why it's called vantage point is because after you inject, you're gonna hear a click, and at the end, the needle is gonna retract back into the tube, the syringe itself. So it's not gonna be a sharp hazard.
Yeah.
So you can throw it in any garbage bin.
So if you're afraid of needle stick injuries or that a child may get a hold of the needle or something, it hides itself back inside the tube, so.
Yeah. But the same mechanism.
Yeah.
Yeah. Cool. Any questions?
So, we can really talk about.
Yeah. I think I'm gonna follow
Yeah,
the
okay,
the steps, and then it's gonna talk about it.
Okay.
So let's open up the instruction manual. And we're gonna go to step 1. So what does step 1 say? Looking for signs of opiate poisoning. So let's define what signs mean. Signs are anything that you can see from the person. So for example, their facial color. If you touch them, their temperature. Any movement that you see, those are signs. Okay. So in here, these signs are going to be what we call adverse drug effects. So those are unintended effects of any medication. For example, so adverse drug effect occurs with any medication. Tylenol is going to have adverse drug effects, right? So that's an unintended effect of Tylenol, etc. So we're just going to learn about the unintended adverse drug effect of opiates, because those are signs we can recognize and say, hey, this is an emergency. We're going to perform an opiate poisoning response. So the first thing that happens with opiates is slow or no breathing. Okay. A normal respiration means breathing rate for an adult is between 12 and 20 respiration per minute. So for an opiate poisoning, anything less than 8 is abnormal. Oftentimes, you're going to see people with respiration that's like 1 or 2 times per minute. So they breathe once every 30 seconds, which is not great. Or they're not breathing at all. Okay, so no breathing at all. The reason why this happens is because opiates, when attached to the receptor, it basically stops the communication between our brainstem, which controls our breathing, and our respiratory organs, which includes our diaphragm. If the diaphragm can't contract, there's no capacity for the lung to take in air, and you don't have breathing, essentially. So it's the neural communication that's being interrupted. Any questions about that? Unresponsive to voice or pain. Well, if you're not breathing, you're not going to be responsive. So that's why. So that's the second part. Now the next part is the skin tone. So all of these are interconnected. The biggest thing is just remember slow or no breathing, and everything else is a symptom of slow or no breathing. So for lighter skin tones, you're going to see the skin, the nail, and the lips is going to appear blue. For darker skin tones, it will appear gray. The reason why is because you have no oxygen in the body. So it's what we call cyanosis. Because you're not breathing, so your perfusion to your tissue, that means delivery of oxygen to the tissue, is going to be reduced. And the color of that is going to be blue or gray. And that's why. Gurgling or snoring sound does not mean this person is sleeping. It actually does sound like the person is sleeping because they're snoring. But the reason actually why is because there's going to be fluid buildup in the airway. And when the air goes through that, it creates vibration, which creates a snoring or gurgling sound. So that's an emergency. Choking or vomiting can occur because when you're unresponsive, your muscles, they don't contract. They don't work anymore. And our airway and our food way is within our throat. The only separation we have is by a little flap called epiglottis. The little flap is not going to work when you're unconscious because your body is not controlling the muscles. So it's very likely that when your stomach is projecting the food upwards because your GI system is not going to work, it's wanting to get it out of the body, it's going up to our food way, and then it's going to go back down to our airway. So what ends up happening is that people actually drown in their own vomit. And our lungs not like any, food or liquid in there. That's why we cough. It's a motion that we naturally have when we choke on water. What happens when we choke on water is because the water is entering our airway, and our body's trying to force the liquid up or whatever is up and away. The same thing happens, except there's no coughing because your body's unconscious. Cold and clammy skin, the same thing that happens is because no oxygen delivery, because you're not breathing. So that's why it's going to be cold because blood is circulating, but there's no oxygen, right? And clammy just means moist. Okay. And then constricted or tiny pupils. The pupil is that opening, the black dot in our eye. Our pupil opens and closes depending on the light. In a dark situation, our pupil opens really wide so we can have more light into our eye. And it closes when there's light, so it constricts. For an opiate poisoning, it's going to be really small. So it's going to be a pinpoint pupil, is what we call it. Seizure-like movement is the only thing that's pretty much going to be dependent on the different type of person. I have seen opiate poisoning with seizure-like movement. I've also seen opiate poisoning with very limpy limbs that you can move very easily. But sometimes you're going to see people who they basically move as one unit. They're very stiff and it's very difficult to move their body. So it depends on the person. So the last one is the one that is not going to be present at every single time. Any questions so far for science?
It's very helpful.
Yeah, basically, if you think about it, if you're not breathing, what's going to happen to the rest of the body? We're not going to be conscious. Our skin is going to look pale or grayish or bluish, right? And, in terms of airway, it's not going to be clear because if there's going to be stuff in there, then it's not going to be effective breathing, and this person might choke or vomit. Okay. Yeah.
So are these symptoms restricted to opioid poisoning? Now, if you see this, you'll know the person is not overdosed on something else.
That's a good question. So the short answer to that is no, but with an asterisk. Because if you're seeing all of these signs, it is most likely going to be an opiate poisoning.
Okay.
If you see one or two, then maybe that's a different story. However, it's safe to assume that if you see all of these signs, it's probably an opiate poisoning. So I talked about benzodiazepine and xylazine. They also have a very similar presentation. But the thing is, if you inject naloxone in them, you're not going to have any effect on them if they are taking purely those substances.
Right.
But the reality is no one is taking those substances alone. So there's I can probably 99% guarantee that there's some sort of opiate in the system as well. So when you're seeing those signs and you inject naloxone, you're going to help because the opiate is going to be blocked. So how naloxone works is that opiate is attached to the receptor. Naloxone comes in, take the opiates out, attaches to the receptor, and inhibits the effect of the opiate. So then your body resumes the communication between the brainstem and the diaphragm, so you can have great pressure differences and air comes in, you're able to breathe again. If you're breathing, then you become conscious. If you're breathing, then your skin is going to resume color, it's going to be back because there's going to be oxygen delivered to the tissue. If you're breathing unconscious, your epiglottis started working, your coughing mechanism started working, you're not going to choke. So all of these goes back. So it's a reversal drug, and that's why. It's because it inhibits the effects of an opiate. Does that make sense?
So if someone was passed out because they, like alcohol poisoning, they just drank so much.
Yeah.
Which of these signs will they not have? That they'll still be breathing, most likely.
They can be breathing or it's slow breathing or no breathing at all in the end. So that's the first sign, right? And they can be unresponsive to voice or pain. But the biggest telltale sign for alcohol poisoning is their smell, right? You can smell it.
Right.
So most likely you're not going to be like, this is an opiate poisoning because of the smell and the context clues. It's probably going to be bottles around, etc.
But
Right.
it could indeed be someone who's doing both.
Yeah, potentially. Yeah.
And what about a diabetic coma?
Yeah, so those are all great questions. And the thing is, in general, there's going to be a lot of medical conditions that look similar to this. But in doubt, using this is not going to injure
Right.
someone.
Right.
Yeah.
And the other thing about the opioid poisoning is that although the breathing is slow, the heart is still working.
Yes, that's the other thing. is because when you find someone experiencing initial opiate poisoning, it's only the breathing part that's being affected. So the heart is still trying to pump because there's some sort of oxygen in the system from before. But the thing is, if you don't respond quick enough, the heart's gonna stop by itself, right? The reason being, the heart is a muscle, and muscle needs oxygen. If you don't have oxygen to the rest of the body, that means you don't have oxygen to the heart muscle itself. So the heart muscle is gonna die because there's no oxygen and it's not gonna function anymore. But most of the times when we find people experiencing opiate poisoning, when you do measure their pulse, the radial pulse, the carotid pulse, or whatever, the pulse is still gonna be there. So that's why you don't teach CPR in this response.
And we'll just read the box at the top because maybe somebody watching the video doesn't have
Yeah.
the pamphlet in front of them. So the box says, check for hazards before approaching and call 911 if it is unsafe to approach. So if you're unsure about what to do, even calling 911 is an action step.
Yes. Yeah, absolutely. Yeah. The second step is checking for responsiveness because this oftentimes, well, first of all, the reason why this is here is because this is probably the biggest determinant of what to do next. So just to summarize, introduce yourself at all times. Talk about what you're going to do and what you're doing. If you're going to touch someone's leg, say that. I'm going to touch your leg to check for responsiveness. I'm going to touch your shoulder to check for the responsiveness. Can you hear me? Things like that help. Okay. So starting with introducing yourself, clapping, the touching the extremities, moving up to the trapezius, okay, or the shoulder. And then, or you can even do the sternum rub, the breastbone. Okay. So those are the steps for responsiveness. Any question?
So here it only mentions rubbing the fist on the middle of the chest. The trapezius pinch would be an alternative.
Yes, absolutely. The reason why I went so much more in depth is because from my personal experience, dropping straight into the middle of the chest is kind of dangerous if the person is responsive, which oftentimes they are going to be. That's why I really go through, start from the voice. Ultimately, if you can just not touch the person, we're gonna try to do that because that's their personal space. So if you don't even introduce yourself and just jump right into rubbing in the middle of the chest and the person's actually sleeping, that's gonna be problematic. Right?
That's a good one.
Well, and one thing that was brought up last week too, with speaking verbally, so many people now have phones, and if they think you might be causing harm, it is a self-protection that they'll be recording you saying all these things and knowing what you're doing. So that was an extra caution.
Yeah.
I thought.
Yeah.
Hi,
So if the
can I
person
ask
is
a quick
unresponsive,
question?
what do we do?
Oh, sorry, just one
Oh.
sec, Bill. Go ahead,
Oh,
Pilar.
sorry. I was just wondering if you could repeat. I'm just having a little trouble hearing. I'm wondering if you could repeat the body parts again that you just said, the chest and the
Yeah.
trapezius. There was just a couple I missed, if you don't mind. I'm just taking notes. So,
Okay, the body parts that you're going to be touching, preferably, are your extremities. So your feet and your hands at first. If there's no response, moving on to the shoulder and pinch the shoulder. Or alternatively, rub the breastbone in the center of the chest. Okay. Does that make
okay.
sense?
Yes, I got it. Thank you. Thank you.
Perfect. Yeah. So if they're unresponsive, what's the action item here?
911.
Call 911 right away. Okay. Get 911 responders. They're also going to guide you. So if you do forget anything else, they're going to tell you exactly what to do. They're going to tell you, are they breathing? So how do we check if someone is breathing or not? Let's say this is, okay, I'll just sit down. Let's say this is a person's head. What we're going to do is the chin and the forehead, and we're going to tilt them upwards, like so. What this means, the other way. Wait, no, this way. Okay. This is the eyes. Okay.
Oh,
Yeah, you gotta tilt them backward like this. The reason being, if someone is unconscious, the tongue, which is actually a muscle, will actually go back to the throat, blocks the airway. So if we're tilting it like this, we're making sure the tongue is not blocking the airway and air can actually go in. If you perform rescue breathing, which is what we're going to do if they're unresponsive, when you start tilting the head back, you're not going to be able to deliver any breath because the air is not going to be going through. Okay. So, how do you check for breathing? Head tilt, chin lift, and we're going to get close to their mouth and nose to hear for breathing. Remember, the person is going to jump back at you because they're unresponsive, right? You're only doing this if they're unresponsive. If they're responsive, you're not going to go this close to the person, right? So you're going to listen and visually, and a lot of people do this. And you look at the scenery. But you need to look down at the chest to see if they're rising or falling. That's what you're looking for. You don't look into the the abyss, but you look down at the chest specifically, see if they're rising or falling, and listening for breathing. So that's the two things you're doing. You're going to count for 10 seconds, no more than 10 seconds. Okay, minimum 5 seconds, maximum 10 seconds. Count like 1 Mississippi, 2 Mississippi, etc. to see if there's any breathing. If the person is not breathing within 10 seconds, this person is not breathing in a normal rate. This person could be breathing, once or twice a minute. But that, remember, is a sign of opiate poisoning, slow no breathing. Right? So if they are breathing and they're breathing quite regularly within a 10 seconds, this might not be an opiate poisoning. Or it could be, but it could be some sort of other emergencies, right? So that's why we call 911. So what we do is put them into a recovery position. I'm going to demonstrate what recovery position looks like. So the arm closest to you. So the person responding is going to be putting the arm closest to them by their side, 90 degrees. The other arm is going to go over the shoulder. You're going to raise the feet up, in the knee up, and then you're going to grab the shoulder and the knee. You're going to roll them over, and then making sure this elbow is in front of the arm. And this way, the person vomits, it goes out instead of down the airway. Okay. So I know that was very hard to demonstrate, so I'm going to do it one more time. So just simply remember, arm by the side, the other arm by the shoulder, raise the leg, and then flip, elbow in front, and kickstand the leg into 90 degrees. Because if you don't, then the person's going to keep on. We can practice afterwards if anyone wants. Okay, so that's what you would do if a person is responsive to this. But if they don't, then you're going to start rescue breathing if you're comfortable. So if you're not comfortable, then you will skip that and you jump into the naloxone, which I'll teach afterwards. But it is important that if you are comfortable and we have a barrier device, what this barrier device does is that it stops the person vomiting into you. It's a one-way barrier device. It means that only you can deliver stuff to them. They can't do it back. So when we open this up, you're going to have two sides. This says this side is up. That means it's toward you. This side is up. If you see it upside down like this, that means you did it wrong. So we got to flip it so that it says you can read the word. This side is up. You're going to put this into the person's mouth, and this side is for you to breathe in. Now, very importantly, when you're delivering a rescue breath, you must pinch the nose and head, tail, chin lift. If you do not pinch the nose, the air is going to go back out the nose because your nose and mouth is connected. That's why we can do mouth breathing and nasal breathing, right? So I'm going to wrap around, cover the nose, and then head, tail, chin lift, then deliver one breath every 5 seconds for 2 minutes, which equates to 24 breath.
Sorry,
Okay,
Bill, what was the timing again?
once every 5 seconds for 2 minutes. Or
Yeah.
once every 5 seconds, 24 times. It's also on the rescue step. Pinch nostril, blow into mouth every 5 seconds for 2 minutes, about 24 breath. The reason why we do this is because the reason of those signs, remember, unconsciousness, pale skin, gurgling sound, is because the root cause is opiate, but the second root cause is the person's not breathing, right? So that's why we're delivering breath, so that the perfusion to the tissue can begin. The person's tissue is not gonna die, okay?
Where it says, let the patient exhale, so if you pinch their nose and breathe in, then do you release the nose? Or do you?
You don't have to, because the mouth,
Oh, because. if
Yeah.
you breathe-
well, you don't cover the mouth, you will
Right,
let the,
right, right.
you're gonna see the chest rise and fall, that's one breath, yeah, and then you're gonna do it again. If you cannot deliver the breath, it means something is wrong, okay? Either positioning, maybe there's something in their mouth, but usually it's positioning. So reposition yourself, pinch nose again, head touching them again, and then try again. Okay, sometimes a seal is not good, so you gotta really cover this person with a good seal, or else the air is gonna leak out, right?
Does that stay sealed for all those breaths, or are you having to release?
You don't have to release, but you eventually have to, because you're gonna have to look down, and that's gonna be loose, right? But when you're doing the breath, really seal it around the face and delivering it when you're doing the breath.
When you're doing the breath?
It's not important to seal when you're not. The 5 seconds waiting, it's okay to let go.
Okay,
Yeah.
just as far as them expelling breath goes, is it important that you pull this out of their mouth?
No,
during
no,
that?
no.
That'll just happen.
Yeah, so basically what I meant is seal it very, very tight. You see how I'm very sealing this? This is during the breath, and pinch your nose, right?
Yeah.
When you are, person is exhaling, just let go. Because when you let go, there's space already, right? There's space here. You do not need to remove it and then put it back, because that's unnecessary time. You can just put it on, that's okay. Yeah. Any other questions? Okay. Now then, just did my tongue again. The next step is naloxone, which I'll demonstrate in a separate, in a second. Gonna jump into naloxone injection point. So, naloxone, let's say this is being delivered. The area preferably we want to deliver is in your upper middle thigh. So here, let me move this down. My pocket. So this is an area where you're gonna inject. Okay? Thigh, this is technically your thigh, not your leg. The leg is actually the lower part, really. So if that thigh is up here, then upper, so means up here, middle. So you're gonna roughly divide it into 3 quadrants. 1, 2, 3. Middle, right here. So you're gonna deliver it to the side. This is a muscle injection. This is where the muscle is the most in the body. Okay, it's your middle thigh.
So when you say the side, do you mean so over here or up here?
By the side.
Over here.
Yeah, by the side. Sorry, this might not be easiest to see, but by the side. Because up here will be in this perspective, I'll be injecting here instead of here. Yeah. If the thigh is unavailable for whatever reason, you can inject it in your shoulder, your middle outer of shoulder. So here. Okay, our shoulder is divided into 3 areas: front, back, middle. So it would be in the middle part.
And it goes through clothes.
Yes. The other thing is goes through clothes. Well, it's not gonna go through like 500 million of clothes. If you have a jacket, I can easily take this off. I will take this off before I inject. So that's just shirts, right? But if I've got pants, it's not gonna go through my pocket, because I don't think anything is gonna go through that. But take that out, and then you can inject it through the clothes, or move it around, inject it. So, any other questions? For injection? Okay. Now, after injecting that, there is still no response, so you're gonna jump back to rescue breathing. Once again, 2 minutes, 24 times, or once every 5 seconds. Then you're gonna go back and forth until EMS arrives, someone else's take over, or the person comes back. Okay. Most likely, the person will come back before EMS or someone else takes over. That's most of the times. It's gonna be the case. So, unless there's some other drugs in the system that requires the EMS transfer. Any questions?
Can we review the putting the naloxone in the needle?
Oh, yeah, I haven't done that, so I'm gonna demonstrate that right now. So I got a little thigh here, so I'm gonna practice injecting that, and you guys can do that afterwards as well, if time permits. I'm gonna let you guys watch me do this first, and then we'll do it afterwards. And don't use your own, because I have got water in here in this vial. So, peeling. Here, there's an arrow. It says peel here. So that's how you can open it. You can also just rip it. Like, it doesn't really matter. It's just harder, right? But they made it live easier for you by demonstrating there's a peel sign. But when we take off this syringe, you're gonna notice there's a cap, which is great because you don't want to jab yourself. This needle is quite long. It's an intramuscular injection, not an intravenous injection, IV. So there's 2 ways. Most people find the first way that I teach much easier. So I'm going to show you the first way, and time permits, I'll show you the second way, which I usually do. Is that you're going to basically pull the syringe down. What this means is that you're gonna the space here isn't a vacuum, right? It's filled with air. So by pulling down, you're getting air inside the space, and then you're going to grab your naloxone vial. In the actual one, you're gonna see a white cap. You're gonna flick that off using your thumb or whatever. You literally just flick it off. It's very easy to do, so I'm not gonna waste that one because that's a seal protect. Then you're gonna notice inside the vial top there's a membrane. It means this needle can go through that. But if you inject anywhere else, it's gonna be solid. You can't go through that, right? You're gonna break the needle. Now, I like to have control. And by having control, what this means is grabbing the needle as close as possible to the tip without touching the needle tip. If I grab it here, it works, but it's harder to control, right? So the closer you are, the more directional control you have. Then grab the vial. If you're on the ground, put it on the ground. Now we're injecting it, right? So I got it in there. It doesn't matter how far you go because we're going to flip it upside down, and then we're going to readjust. Basically, the tip, the very tip, that means the top part of this has to be in the neck.
In where?
In the neck of the vial. What do I mean by that? The neck is the narrow region of the vial. The rest of this is the body of the vial. The tip of it has to be in the neck, means, or else you're gonna inject air. Okay? If I'm all the way up here, it's gravity, not the entire vial is filled with fluid. It's gonna go down to here. So all the rest here is air. Right? You're gonna draw air. You can't draw any fluid. Right? But if I pull it down, so the tip of it is in the neck, which it is right now. Look how much space is left in here, right? And what I'm going to do is I'm gonna push the air into the vial, and then it's gonna come out with liquid. Okay, so you're gonna see, and the fluid's gonna come out all by itself, and you can start pacing it by pulling it down. Right, there you go. That's it. You're pulling every single droplet of it. Well, not every single, but the entire bottle, essentially, right? There's some here, but I don't really care about it because that's good enough. Take it out. Gonna push it out a little bit.
Get the air out.
Yeah, some air bubble in there, which is not a problem. Again, it's not an IV injection. It's an IM injection. Okay. Then how we inject this is the thigh, pretended. Straight down, 90 degrees, perpendicular to the surface of the injection. So if it's a deltoid, or the shoulder, you're going to do it like this. If it's the thigh, you're going to do it straight down like this, perpendicular, always 90 degrees to the muscle you're injecting. Okay, you're not gonna do this, you're not gonna do that, straight down. Okay, how I like to hold it is through 2 fingers, holding the vial like this, not the vial, the syringe like this, and the thumb to control. Thumb controlling is important, I find, because the thumb is usually the strongest in controlling this, right? So we're gonna inject it down, and doesn't matter how much you can do all the way, halfway, as long as you get some needle in there. And then I'm gonna put it all the way, you can hear it click. So not yet. So you hear it click, and then the syringe is back inside. Okay, so I can't hurt anyone. Yeah. Okay, so that's how that works. And if you have to do 2 or 3 times, I like to rotate the areas of injection. It's not a big deal. It just hurts less if you.
And why would you do 2 or 3 times? I mean, if because you're hoping for response, is that
Yeah.
why?
So if they're unresponsive,
I'll just try again.
But you go back
How
to
much
breathing.
time do you do? Give them between
Yeah.
one injection and then thinking, oh, maybe I need another.
2 minutes, 1 to
2
2 minutes, because it takes about 2 minutes for naloxone to take in back.
You go back to the rescue breathing.
That's why you go back to rescue, because at the time you're giving breath, but also you're waiting for the naloxone to actually go effect. That's why. Yeah. But if you are not comfortable doing that, then you just kind of keep stimulating, right? And try to see if there's any response.
But what is the duration of this opioid within the body? Can they?
It's gonna be range from 20 to 90 minutes. It's a very big range. That's why we call number 1. It's because the body's opiate usually does not exit before the naloxone does. Naloxone sometimes exit before the opiate does. So what that means is the opiate is gonna go back and reattach to the receptor. Then you can have a secondary poisoning. Now I'm gonna be honest, I've never seen that before. In 18 times I haven't responded. But I've heard it happen as well. The reason being, fentanyl is usually a pretty fast acting opiate, which is the most common substance that we see on the street. So they exit the body pretty fast. So that's why you don't have, secondary poisoning happening very often. Yeah. Any questions?
So the illustration doesn't really show pulling back on the syringe before you insert it into the neck.
Yeah. They don't really show you anything.
Yeah.
So I can show you the second way that I was taught, which is the primary way that I use, which is a bit more difficult for new beginners, I feel. Sorry, I'm just getting water in here first.
Yeah, but I'd like to get the first, if it's okay with you, I'd like to get the first, just to review the first way of, if you could. So you pull it down to get
Air.
inside.
Yeah.
You insert it into the
Bye.
neck of the vial, making sure that it's the tip.
You gotta flip it upside down first.
Yeah.
Yeah. Let's
It
grab it.
seemed as though you were pushing it, then.
Yes, I'm pushing back the air to the vial so
Yeah.
that it will come out with the liquid.
Okay, because
automatically.
it doesn't show that either.
Yeah, this doesn't show you like basically anything. Yeah, it just says pull back on the plunger. So I'll show you the way that they teach you here,
Okay.
which is harder, most people find, because it is very hard in the beginning. People are like, what, why can't move this? Because you gotta use a little bit more force. But then they do that and it just pop out.
Whoa.
So
Oh,
Demo what you showed us again, like a
Yeah.
second time.
What
First-
happens
yeah.
if it comes out? If that happened, can you stick it back in and reuse that needle?
yeah, I could do that back in, but if you got liquid in
Yeah,
it, it's gonna
understood.
all fall off.
Yeah,
So
yeah.
I can't just collect that back
No,
into the
understood.
vial.
But if it pulls out, the needle is still able to be used.
Yes,
Yeah, got
I'll
it.
put it back in and I'll demonstrate right now. So do you want me to demonstrate the way that I just did?
To
Yes.
redemonstrate the first one, then we can actually put notes down.
Okay, yeah.
If you don't
So-
mind.
Cap off. I'm going to pull down usually you pull down a millimeter, because that's how much is in here. It doesn't really matter, I can pull down here, whatever, right? As long as there's something pulling down, okay? And then I'm gonna put this inside the vial. And then next thing is very important, you gotta do upside down. If you don't do upside down, the liquid's not gonna come down, because it's gravity drawn, right? Now, I already put in a tip, in the neck region, well, not really, here, there you go, okay? Then I'm gonna push this in the vial. What I'm doing is I'm injecting air into the vial, and it's gonna resist it, because when you inject stuff in there, like there's only limited space, right? You inject, something's gonna come out, or else you can't inject it. And you see the fluid come out automatically, right?
So there's no need to pull back on the plunger as it instructs us here.
You can help pull it back faster,
Yeah,
right? Or I'll do it again.
okay.
Oh, my bad. I'll just eject these. Okay. All right, so upside down, making sure it's in the neck. Now I'm gonna inject some air. And it's gonna be slow. To hasten it, you just pull back down, right? So I'm hastening it, so I'm just pulling back down, so more comes out faster. But you don't have to do that if you don't want to. But at the end you will, because there's some fluid there that really requires you to pull down. But it's gonna take forever for it to drip.
I think when we did this the first time, it was helpful for me to know to put the vial on a
On the third,
Yeah.
surface.
you're doing this, it's fine,
Because
but
otherwise you're,
yeah. So that's the most people prefer that way. It's faster, it's easier. I don't know why I did that. But I'll show you the way that they usually teach. Okay, same thing, right? I open this, cap off. I'm gonna now put it here. Upside down, making sure it's in the neck. Now I just pull. Pull down. All I do is just pull the syringe down.
But you didn't put air in first this
No.
time.
No,
Okay.
you don't have to.
Okay.
If you do that, it's just faster,
Okay.
right? This is both ways work, right? Now, this one you really need to help pulling it. If you don't pull, it's not gonna do it. Now, the issue that I see most people have is they pull too far, like down here, and then boom, liquid gone. Or they don't pull enough, and also you can go back and forth, right? To help getting the liquid down. There's nothing there, but pulling down back and forth. Because you just do this, you're gonna run out of space eventually. So you gotta push back in a little bit and then go down. Right. But most people find that very confusing. That's why the first way is usually the best one.
First way is the best.
Yeah.
Yeah.
First way is easy. All you do is just you remember to pull air, which is easy to do, right? Then you put it here, upside down, and then inject the air, and boom, it drip out.
But
Right.
you have to remember to pull the air
Yeah.
in before you insert it.
Yeah.
Yeah. Well, I mean,
Yeah. But you did say because it's intramuscular, it's not gonna cause the harm that would if you have air going
I know,
intravenous.
but you worry about air,
Yeah.
air bubbles going.
yeah. The reason why we worry about that is because for veins, when you go to the head, the veins are very small. So air bubbles can create blockage, right? But this is going to the muscle. So I'm gonna pull this out, and then I'm gonna just push that a little bit. Comes out. It's not a problem. There's no problem. Again, so air bubble is not gonna go out easily. So I'm just gonna go ahead and inject. So I'll show you what happens if you don't activate this trigger. So you're gonna pull out, oh, the needle is still in here. What do? Don't jab them back in and activate it, which people do. Activate it outside, right? So I'm gonna show you what it looks like. Boom,
Oh,
right
just
there.
push it again.
Yeah,
It's a
Yeah,
very
just push
clever
it again.
design.
and there you go. You can't hurt anyone. Yeah.
So if it doesn't go back in, it means that you didn't leave
didn't
the
click hard
injection in until the click sounded.
Yeah, the injection will be in there. It's just you didn't click hard enough for it to go back in. Yeah. So, just push it, activate the safety afterwards. Yeah. Any questions? Okay. I am worried about time, so I don't know if it's enough time for me to practice,
yeah. I
but
think
the
so.
instruction is done.
Yeah,
Yeah,
And I
No,
guess we
that's
should
good.
put the gloves on before we start.
Right.
absolutely you should, because you're gonna be touching the person.
And then do we rub the,
Oh.
if you're doing on skin?
So this is not for skin per se, it's usually for the vial. So you flip the white cap off, you can use this to clean the top before you inject. But I never have done that in my life, so I just usually do it. Cause it's, right now it's
sterile.
sterile.
It's sterile.
What
Yeah.
if you were going to inject and for whatever reason, the skin wasn't clean, would you use that?
Wasn't?
Yeah,
The victims.
Yeah.
Or the casualty.
I think it depends on what they have. If they have an open wound, I'm not gonna inject there,
Okay,
right?
yeah.
So that's the first thing. If there's any wound there, I'm not gonna inject it right into the wound.
right.
So I will find another space where there's, you know, like what I did was that any region of the thigh is fine. You inject a bit closer to the top, a little bit closer to the bottom. It's just comfort level for them. Because the less muscle, the more painful, right? You're injecting close to their bone, that's gonna be more painful for them.
But if someone has a t-shirt on and their skin is exposed and they've been outside for how many days, would you then do a quick wipe of it before you did the injection?
Again, you could, but I have never done that, just
Okay.
because the faster I can deliver this, the better.
Right,
Yeah.
okay.
But you could, if you want to.
I had assumed that when I first saw the kit, that these were for casualty
yeah.
skin.
But the thing is, most times I'm not even gonna be exposing the skin.
Right.
Most times I'm just going to the clothing. I've never
Right.
done to the skin except for like twice with the shirt.
Yeah.
But usually go for the thigh, right? But for the thigh, you gotta pull the hands down and stuff like that, so I don't do that.
In the times that you have had the opportunity to do this on people that needed it.
Yeah.
Have they responded quite quickly? Is there anything that you want us to know
Yeah.
about it?
Absolutely. So I mentioned in the beginning that there's oftentimes other substances involved when you're delivering it. So what happens is you're gonna see the person begins breathing, right? They're breathing fine, but they're still unconscious. And no matter how many naloxone you give, 500, whatever, it's still not gonna cause them to wake up. The reason being is because they have another substance in their body acting on their consciousness. So as long as you see them breathing, you can rest assured that naloxone isn't working. Now you have to consider there's maybe another substance. That's something you can tell 911. Person is breathing but unresponsive, and they'll know. Okay, this is probably something else. EMS, when they arrive, they will know.
So that's why we call 911 first,
Yes.
because
absolutely.
we don't know all of these complications
Yeah.
that could be involved.
Yeah, you can't. You don't have, even a medical professional without equipment, also like how much to know, like.
So when you do the naloxone and they start breathing again, but 911 still hasn't come and you keep checking their breathing, even if they're not responsive, and then you may need to do this again if their breathing gets much shallower or much slower.
Yeah, so remember over here, it says if they're not breathing, then you put them to recovery position. So that's what exactly. Person start breathing and conscious, recovery position. Any situation. Person is fainting, not because of open poisoning, but like anything else, recovery position. Yes. So yeah, if someone is about to faint, put them to the ground first, and let them faint like that. And if they're fainting, usually takes a few seconds. Outside of open poisoning, but in general, like so, yeah.
And if the naloxone helped them to regain consciousness, how long have you experienced that, like, can people come wake right up and want to leave?
Most of the time, they don't want EMS to
Right,
come.
that's
So
what I was
that's the other
wondering.
thing. We called EMS because we assume this person wants to live because the person is unconscious. And that's kind of what we call implied consent, legally speaking. Now you can't hold someone against their will because if they're awake, then they can make decisions for themselves. Right. So you can inform EMS, saying the person just woke up and walked away. They can tell them where they are actually walking, but legally they can approach and ask if they want EMS. They say no, they can't do anything. They'll just leave.
So if they're conscious, they won't just do. Yeah, and with all your different experience, have you found people wake up in all sorts of different states, like sometimes angry or sometimes
Yeah,
passive,
most
or-
of the times it's confused. It's like, what the hell just happened?
Mhm.
Then it's your job to explain to them,
Mm.
you've experienced an opiate poisoning. I have injected naloxone in you, and now you're conscious. 911 has been called. EMS is on the way. Now this is the validation part. I understand that you might feel a lot of pain right now. It's very uncomfortable, and just kind of do your report building, right? And if the person decides to leave, you get them to leave. Like, that's fine. Don't stop them, because you can't stop them, right? Just uniform EMS. But yeah, person might wake up and be like, what the hell? You just now I feel like shit, right? Because you're going to withdraw. It's not about the high, it's about the withdrawal.
Oh,
The withdrawal is really horrible, right? It's
Mm.
really, really painful.
oh,
When someone is dependent on opiates, when their body becomes naturalized to the sense that they need opiates to live. They need opiates to feel normal. That's their baseline, right? That's why you have use to maintain. That's how opiate agonist treatment, some of the treatments actually work. Is they replace the opiates with a different opiate, but that opiate is more controllable, essentially, right? So if you take the opiates away, their body, becomes very painful. Any sensation of touching it becomes very sensitive. It's like burning, right? And with long periods of withdrawal, it feels like the worst type of influenza you've ever felt in your life, right? The muscle ache, the sweating, the vomiting, all that kind of stuff, but 10 times worse. So
So if 911 comes and they take them to the hospital, what kind of treatment what will they do? in the hospital?
monitoring, probably. Just monitoring, seeing whether or not there's when there's a long period of exposure to lack of oxygen, there might be some brain injury as well. So they'll probably be monitoring for that. They'll probably monitor if there's any secondary poisonings. But usually they don't even, people don't want 911. Yeah. But it's important to call stuff.
Right.
Is it okay if we wrap up the Zoom? I just gotta go get.
Yeah.
Yeah.
Things going.
Perfect.
Thank you, Pilar.
Thank you.
Yeah.